Welcome back to the Deep Dive. Today we're tackling something truly fundamental, the incredible precision behind birth itself. We're diving into the physiology, the mechanics, everything involved in what clinicians call uncomplicated intrapartum care.
That's right. We've got some really comprehensive source material here. Think of it as the definitive guide, really, for what happens right from the moment true labor kicks off.
Yeah, and our mission today is pretty clear. We want to break down this whole process, the stages everyone talks about, those mechanical factors, the famous 5 Ps, and crucially, weave in the human side of things, the emotional context, cultural safety.
Absolutely. Because understanding what happens is one thing, but grasping why it matters, how all these tiny details fit together for safe, person-centered care, that's the goal.
It's complex stuff, no doubt. So think of this as maybe a master class in pulling it all together, taking the technical details and connecting them back to, well, compassionate care.
Exactly. It's about synthesis. And it all starts, interestingly enough, well before the main event, with some early signals the body sends out.
Okay, let's unpack this. So before we even get to what most people think of as labor, there's this sort of countdown phase. Clinically speaking, labor is defined pretty precisely, isn't it?
It is. Labor is the process of moving the fetus, the placenta, and the membranes out of the uterus. And technically, it starts when the cervix begins to dilate progressively.
But the body's been gearing up for weeks sometimes. There are these signs, sometimes called false alarms, which isn't quite right, is it?
No, prodromal labor is a better term. But even before that, you get these pre-labor signs like Braxton Hicks contractions. People feel them. They can be quite strong.
Right, strong, maybe frequent towards the end. So why aren't they the real deal?
The key is they're irregular. They don't get stronger or closer together in a predictable way. And fundamentally, they don't cause the cervix to change. No dilation, no effacement. Think of them as uterine warm-ups, maybe.
Okay, warm-ups. Makes sense.
Yeah.
Then there's lightning, the baby dropping.
Yes, particularly in first pregnancies, maybe 2 to 4 weeks before term, the uterus sinks down and forward. The baby's head settles into the true pelvis.
Which gives the mom a bit more breathing room, I suppose. Less pressure up high.
Exactly, less pressure on the diaphragm. But like you said earlier, the pressure just shifts
Oh, okay. Where does it go?
down onto the bladder. So you often see a return of needing to pee more frequently. It's a trade-off, really. Diaphragm space for bladder space.
Right. And what about that burst of energy some people report, the nesting instinct?
Oh, yeah, that's well documented. A sudden, sometimes quite intense urge to clean, organize, get everything ready. It often happens just maybe 24, 48 hours before labor really starts. Then exhaustion might hit again.
Interesting. Any other physical clues?
Definitely. There can be a persistent low, dull backache from the pelvic joints relaxing, that's the hormone relaxant at work, and changes in vaginal discharge, often called the bloody show.
Bloody show. That sounds dramatic.
It's usually just brownish or blood-tinged mucus. It happens because the cervix is becoming congested and starting to soften, maybe losing its mucus plug. Also, sometimes diarrhea or even a small weight loss.
Weight loss, just before labor. Why?
It's typically about half a kilo to maybe 1.5 kilos. Mostly water loss driven by electrolyte shifts as hormone levels change, progesterone drops relative to estrogen. It's like the body is trimming down slightly for the big effort ahead. Hashtag 1.2, true versus prodromal labor.
Okay, so we have all these hints and nudges from the body. But how do we, or more importantly, how does the person experiencing it know when it transitions from these warm-ups to true labor? What's the definitive line?
That's the million-dollar question for anyone nearing their due date, isn't it? And clinically, it's crucial. We use prodromal labor now, not false labor. The uterus is contracting.
But not effectively.
Exactly. In prodromal labor, the contractions are irregular, maybe felt mostly in the abdomen or groin. And critically, they often ease up if you change position, walk around, take a bath. And the absolute key, no progressive cervical change. The cervix isn't dilating or effacing.
Got it. So true labor is different because
True labor contractions have a pattern. They often start low in the back and wrap around to the front. They become regular, predictable. They get longer, stronger, and closer together over time.
and moving around doesn't stop them.
Nope. Changing position, walking, none of it makes them go away. And the definitive sign for clinicians, we see progressive cervical effacement and dilation on examination. That's the only true measure of labor progress.
So what actually flicks that switch? What starts this unstoppable, coordinated process? You mentioned hormones earlier. It's not just one thing, is it?
Not at all. It's a complex hormonal cascade, like an orchestra tuning up. A key factor is progesterone withdrawal. Progesterone keeps the uterus relaxed during pregnancy. As its levels drop near term, the uterus gets much more sensitive to things that make it contract.
Okay, so the brakes come off slightly.
Precisely. And at the same time, estrogen levels rise, which dramatically increases the number of receptors for oxytocin on the uterine muscle cells. The uterus becomes primed.
Ready for the go signal.
Right. And then the stimulants arrive. Oxytocin, released from both the mother's and the baby's pituitary glands, directly stimulates those powerful contractions. Plus, prostaglandins are produced.
Where do they come from?
From the fetal membranes and the lining of the uterus, the decidua. Prostaglandins don't just help contractions, they're crucial for cervical ripening. It's basically softening the cervix, making it ready to dilate.
And didn't the sources mention the fetus itself playing a role? The fetal cortisol theory?
Yes, that's fascinating. As the baby's adrenal glands mature, they produce more cortisol. This fetal cortisol is thought to signal through the placenta, potentially reducing progesterone production further and boosting estrogen and prostaglandin synthesis in the mother.
So the baby essentially says, okay, I'm ready.
In a hormonal sense, yes. It contributes to creating the perfect storm of conditions needed for labor to begin. It's a really elegant feedback loop. Hashtag tag 1.3. Emotional and cultural safety.
That idea of the baby signaling readiness is incredible. Okay, let's shift gears slightly from the pure mechanics. The sources really emphasize the emotional and cultural context running alongside all this physiology.
Absolute critical. Labor isn't just a physical event, it's a profound human experience. And how someone feels emotionally can actually impact the physical process.
How so?
Well, the emotional state varies hugely, right? Someone might feel euphoric, intensely focused, maybe even experience a bit of amnesia between contractions because the pain takes over. But high levels of anxiety or fear can interfere with labor progress.
So managing fear isn't just about comfort, it's physiologically important.
Definitely. Intense fear can trigger the release of stress hormones, like catecholamines, and these hormones can actually inhibit the release of oxytocin and slow down cervical dilation. So, providing good emotional support, clear communication, just being present, these aren't nice-to-haves, they can be vital interventions.
And this support needs to be culturally sensitive. The sources were very strong on this point.
Extremely. Cultural beliefs about pain, who should be present, preferred positions, even whether silence is expected. These deeply shape the experience. Care providers need to approach this with genuine cultural humility.
What does cultural humility look like in practice during labor?
It means recognizing you are not the expert on the patient's values or beliefs. The family is. It's about asking, listening, and adapting care to align with their preferences. Crucially, the patient gets to define whether the care feels safe and respectful to them.
This links directly to trauma-informed care principles, doesn't it? Safety, trust, choice, control, compassion, collaboration. How do those play out?
They are paramount in labor. Safety means explaining everything before you do it. Trust means getting explicit permission every single time you need to touch the patient for monitoring, for an exam, anything.
Every single time.
Every single time. Choice and control mean offering options whenever possible, different positions, ways to cope with pain, who they want in the room. It's about restoring agency in a situation that can feel very overwhelming and out of control.
And avoiding certain language, I imagine.
Absolutely. Using non-judgmental language is key, avoiding commands like, open your legs, and instead explaining why you need to do something and asking permission, like, may I check your progress now to see how things are moving along. Limiting invasive procedures to only what's medically necessary. It all builds towards collaborative, respectful care, which, as we said, supports better physiological and psychological outcomes.
Okay, so we've covered the emotional and hormonal lead-up. Now let's get into the mechanics, the physics of birth, guided by those 5 Ps. We've touched on psychological response, so let's start with P1, powers, the engine driving this whole thing.
Right. The powers are split into primary and secondary. Primary powers are the involuntary uterine contractions. These are the engine. They start true labor, and they do the fundamental work of changing the cervix.
Changing the cervix meaning effacement and dilation.
Exactly. Effacement is the thinning and shortening of the cervix. Think of it like a thick turtleneck being pulled up and becoming thinner. It's measured from 0 to 100%. Dilation is the opening of the cervix, measured from 0 centimeters, fully closed, to 10 centimeters, fully open.
And how do the contractions achieve that?
The powerful muscles in the top part of the uterus, the fundus, contract and pull upwards on the lower part of the uterus and the cervix, basically drawing the cervix up and open. It's an amazing mechanical process.
So those are the primary involuntary powers. What are the secondary powers?
Secondary powers are the voluntary pushing efforts, the bearing down. These come into play later in the second stage of labor, once the cervix is fully dilated. They help to actually push the baby out.
So they don't dilate the cervix, they just add expulsion force.
Correct. They augment the primary powers for the final expulsion.
Okay, and when we assess these contractions, these primary powers, what are we looking for? What defines an effective contraction pattern in active labor?
We measure three key things. First, frequency, how often they come. That's time from the start of one contraction to the start of the next one. In active labor, usually every 2 to 5 minutes.
Okay, start to start.
Yep. Second, duration, how long each contraction lasts from its beginning to its end. Active labor contractions typically last around 60 to 90 seconds.
Long time. And intensity, how strong are they? How do you measure that?
Intensity is usually assessed by palpation, feeling the uterus during a contraction. It's subjective, but useful. Mild feels like touching your nose, easily indentable. Moderate is firmer, like your chin. Strong feels rock hard, like your forehead, you can't indent it.
Nose, chin, forehead. Got it.
But there's one more crucial aspect of assessing powers, and it's all about safety. That's the resting tone.
What's that?
It's how the uterus feels between contractions. It absolutely must relax completely. It should feel soft.
Why is that relaxation period so critical?
Because during a contraction, blood flow to the placenta is significantly reduced, sometimes even temporarily stopped. That rest period is when the placenta refills with oxygenated blood for the baby.
Ah, so no rest, no oxygen.
Essentially, yes.
Yeah.
If the uterus stays firm or hard between contractions, what we call hypertonic resting tone or uterine hyperstimulation, the baby isn't getting enough oxygen. It's a sign of fetal stress and needs immediate attention, like giving IV fluids or stopping any oxytocin infusion. That rest is non-negotiable for fetal well-being.
That makes sense. The need for rest links perfectly to the next P, the passageway, the path the baby has to travel, and P4, position, which is about how the baby relates to that passageway. It's not just a straight tube, is it?
Far from it. The passageway involves the bony pelvis, and we really only care about the true pelvis, the inlet, mid-pelvis, and outlet the baby navigates. The flared part on top, the false pelvis, doesn't really play a role.
But it's not just bone, right? There's soft tissues involved too.
Crucially, the lower part of the uterus stretches thin. The cervix has to open completely, the pelvic floor muscles need to stretch, the vagina distends, and finally the introitus, the vaginal opening. All these soft tissues form part of the passageway.
And can things obstruct this path besides just bone structure? The sources mention soft tissue issues.
Absolutely. A very common one is full bladder. It sits right there in front of the uterus, and if it's full, it can physically block the baby's head from descending properly.
So emptying the bladder is actually a labor progress intervention.
It can be. Catheterization is sometimes needed if the person can't empty their bladder. Other obstructions could be things like large uterine fibroids or rarely pelvic tumors, which might necessitate a C-section. Regular checks are important.
Okay, so assuming the path is clear, how do we track the baby's journey down? What's the terminology? This is where position comes in.
We use specific landmarks. First is engagement. This means the widest part of the baby's presenting part, usually the head, has passed through the pelvic inlet and reached the level of the ischial spines.
The ischial spines. Those are bony points inside the pelvis.
Yes, you can feel them on internal examination. They're our key landmark. Engagement means the baby is truly locked in for the journey through the true pelvis.
And those spines define the baby's station.
Exactly. Station tells us how high or low the presenting part is relative to those ischial spines. If the lowest part of the baby is right at the level of the spines, that's station 0.
Okay, 0 is level with the spines. What about above or below?
If the baby is still above the spines, the station is negative, -1, -2, up to -5 centimeters above. If the baby has descended past the spines, the station is positive +1, +2, down to +5 centimeters, which is right at the outlet, crowning.
So if someone has really strong contractions, but the baby stays high, like -3 station, that's a red flag.
Big red flag. If the powers are good, but the baby isn't descending, so the station isn't changing, it could mean the baby's head isn't flexed properly, or, more worryingly, cephalopelvic disproportion, CPD.
Meaning the head is too big or the pelvis is too small.
Precisely. The geometry isn't working. It suggests a potential obstruction and needs careful assessment, possibly leading to intervention.
Right. That leads us perfectly to P3, the passenger,
Yeah.
the fetus itself. Here's where it gets really interesting, because the baby isn't just a passive block. It has to orient itself just right to fit. We need to talk about lie, attitude, and presentation.
Exactly. First, fetal lie. This is simple. How is the baby's spine lined up with the mother's spine? Ideally, it's longitudinal or vertical. They're parallel. That's what we want.
And if they're not parallel,
If the baby is lying sideways, that's a transverse lie, or horizontal. That's a major complication and usually requires a C-section unless the baby can be turned. An oblique lie is somewhere in between.
okay, so lie is the overall orientation. What's fetal attitude?
Attitude describes how the baby's body parts are related to each other. Think posture. The ideal attitude is general flexion.
Flexion means tucked in.
Yes, perfectly tucked. Chin pressed firmly onto the chest, arms crossed over the chest, legs flexed up at the knees, back rounded. This creates the smallest possible shape, like a compact little egg,
Why is that so important?
because it presents the smallest head diameter to the pelvis, which we'll get to. Any extension, any untucking makes the baby effectively larger and harder to fit.
Got it. Lie, attitude,
Yeah.
then fetal presentation. What part is coming first?
Exactly. Presentation is the part of the fetus entering the pelvic inlet first. The most common and best is cephalic or vertex presentation, where the back of the head, the occiput, leads the way.
And other possibilities.
Breech presentation, where it's buttocks or feet first. Or, if the lie is transverse, it might be a shoulder presentation. Less commonly, you can have face or brow presentations if the head is extended instead of flexed.
Okay, so once we know it's head first to phallic, we need more detail. That's fetal position, using that three-letter code, right?
Yes. This code tells us precisely how the presenting part is oriented within the mother's pelvis. It's logical once you break it down.
Let's try. First letter.
First letter tells you which side of the mother's pelvis the presenting part is facing. L for left, or R for right.
Okay, left to right. Second letter.
Second letter specifies the presenting part itself. Usually O for occiput, the back of the head in a vertex presentation, but it could be S for sacrum in a breech, M for mentum, chin, in a face presentation, or SC for scapula, shoulder.
Right, O for occiput is the common one. Third letter.
Fourth letter tells you whether that presenting part is pointing towards the front, anterior A, the back, posterior P, or the side, transverse T, of the mother's pelvis.
Okay, let's put it together. ROA.
ROA means the baby's occiput is on the mother's right side and it's pointing towards the anterior or front. That's generally a very favorable position for labor.
And LP.
Left occiput posterior. The occiput is on the mother's left but pointing towards her back, her posterior. This often means a longer labor, more back pain, back labor, because the hard part of the baby's skull is pressing on the mother's sacrum. The baby usually needs to rotate further to get out.
It all comes down to fitting the head through the pelvis. The fetal skull can mold a bit, can't it? The sutures and fontanelles help.
They do allow for some overlapping of the skull bones, which is called molding, but the critical factor determined by that fetal attitude flexion is the diameter of the head being presented.
This is the geometry problem you mentioned.
Exactly. When the baby is in that perfect general flexion, chin tucked tight, it presents the smallest possible front to back diameter of the head. That's the suboccipitobrachmatic diameter, or SOBD.
And how big is that?
So it's about 9.5 centimeters. That's the magic number, perfectly designed to fit through the pelvic outlet.
But if the baby isn't fully flexed, if the attitude is off,
Then the diameter presented gets much larger very quickly. If the head is only partially flexed, a sinciput presentation, it presents the occipitofrontal diameter, which is around 12.5 centimeters.
wow, 3 centimeters bigger already.
And if the head is even more extended, a brow presentation, it presents the occipitomental diameter. That's a huge 13.5 centimeters.
13.5 centimeters versus 9.5 centimeters. That sounds impossible for most pelvises.
It usually is. Those larger diameters simply won't fit. They prevent engagement, they prevent descent, labor stalls. It highlights just how vital that flexed attitude is. It's pure mechanics the passenger has to adopt the optimal shape to navigate the passageway.
So, assuming the baby's in a good position and attitude, it still has to perform this complex sequence of twists and turns to get through the curved pelvic passageway. These are the 7 cardinal movements. There's a mnemonic for this, right? Every descent female I employ rises extremely.
That's the one. And these movements aren't random. They are mechanically necessary steps the baby must take, primarily the head, to align its smallest diameters with the largest diameters of the mother's pelvis at each level, inlet, mid-pelvis, outlet.
Okay, let's walk through them using the mnemonic. E is for engagement.
Right. We talked about engagement, the head entering the pelvic inlet, usually at the level of the ischial spine's xerostation. We also look for synclitism here, meaning the baby's head is level, parallel to the pelvic plane. A little tilt asynclitism can sometimes help it negotiate the inlet, but too much tilt is a problem.
D is for descent.
Descent is simply the downward journey through the pelvis. It happens throughout labor, driven by contractions, fluid pressure, and later, pushing.
F is for flexion. We covered this, but it's a distinct movement.
Yes, it happens as the head descends and meets resistance, usually from the cervix or pelvic floor muscles. This resistance forces the chin onto the chest, achieving that crucial small SOBD diameter, 9.5 centimeter.
E is for internal rotation. This sounds key.
Absolutely vital. The head usually enters the pelvis with its widest diameter aligned with the pelvis's widest inlet diameter, which is side to side, transverse. But the widest diameter of the outlet is front to back, antero-posterior. So the head has to rotate, usually 90 degrees, so the back of the head faces forward under the pubic bone. If it starts posterior, LOPROP, it might need to notate 135 degrees. Without this rotation, birth can't happen.
Okay. E is for extension.
Once the head gets past the pubic bone, the passageway curves upwards. So the head has to extend, the neck pivots, and the head comes out. First the back of the head, occiput, then the face, then the chin, sweeping past the perineum.
R is for restitution external rotation. 2 parts.
Kind of. Once
Okay.
the head is born, it naturally turns back slightly, restitution, to line up with the shoulders, which are still inside. Then, as the shoulders rotate internally to fit the pelvic outlet, the head rotates further externally. It's basically the head realigning with the body.
And the final E is for expulsion.
Expulsion is the delivery of the rest of the baby. First, the anterior top shoulder slips under the pubic bone, then the posterior bottom shoulder sweeps over the perineum, followed quickly by the rest of the body, and that's birth. Hashtag 3.2, fetal and maternal physiological adaptation.
Wow. While the baby is doing all that gymnastics, the mother's body is also undergoing some incredible adaptations. Let's talk about what's happening physiologically for both of them during this intense process. How's the baby coping?
Well, fetal well-being is monitored closely, usually via the heart rate. The normal range is 110 to 160 beats per minute. We expect to see some accelerations in the heart rate, which is good. Sometimes we see early decelerations, temporary dips that mirror contractions, often due to head compression, which is usually benign.
But the contractions squeeze the placenta, reducing blood flow, right?
They do. Each contraction temporarily decreases perfusion. A healthy baby has reserves and compensates for this intermittent stress. It's a tough process, but they're built for it.
And isn't this process also preparing the baby for breathing outside?
Absolutely. The pressure of passing through the birth canal helps squeeze fluid out of the baby's lungs. Plus, the relative lack of oxygen and buildup of carbon dioxide during labor triggers chemical changes that stimulate the respiratory centers in the baby's brain, prompting that first crucial breath right after birth.
Okay, and what about the mother? The cardiovascular system must be working incredibly hard.
Phenomenally hard. During each contraction, a significant amount of blood, maybe 300 to 500 milliliter, is squeezed out of the uterus and back into her general circulation. Her overall cardiac output increases dramatically.
How much?
By the end of the first stage, it can be up to 51% higher than her pre-labor baseline. And interestingly, it peaks about 10 to 30 minutes after the birth. It shows the sheer scale of the physical effort.
Wow. Any other systems under strain? We should watch out for supine hypotension too, right? Lying flat on the back.
Yes, definitely. The weight of the uterus can compress the major vein returning blood to the heart, the vena cava, if the mother lies flat on her back, reducing blood flow and causing dizziness or faintness. Tilting her position is important, and other systems adapt too.
Like the digestive system, does it just stop?
Pretty much. GI motility slows right down, absorption decreases, stomach emptyings is delayed. It's partly the hormones, partly the stress response. Nausea and vomiting aren't uncommon, especially later in labor, sometimes as a reflex when the cervix becomes fully dilated.
Okay, let's put this all together and walk through the stages of labor as they happen clinically. Stage 1 covers the period from the onset of true labor until the cervix is fully dilated. It starts with admission, right? What's key then?
Admission assessment is crucial for triage. First, confirm it's actually true labor, not prodromal. Review her history, due date, any risk factors. Perform Leopold maneuvers, those external belly checks, to get an idea of the baby's lie, presentation, and position. And critically, determine the status of the amniotic membranes. Has her water broken?
Spontaneous rupture of membranes, or SROM. If that happens, what's the immediate priority?
Check the fetal heart rate immediately for at least a full minute. There's a risk the umbilical cord could be compressed or even slip down past the baby's head, prolapse, once that cushion of fluid is gone, especially if the head isn't well engaged.
And you assess the fluid itself.
Yes, using the acronym CODO, Color should be clear, maybe straw-colored. Odor shouldn't be foul. Amount, trickle or gush. And time, when did it happen? If the fluid is greenish or brownish, that's meconium staining, which could indicate fetal stress and requires closer monitoring.
Then there's the internal check, the sterile vaginal exam, or SVE.
Right. The SVE tells us definitively about dilation, effacement, station, presentation, and position. But, and this is important, we limit SVEs, especially after the water breaks. Each exam increases the risk of introducing bacteria and causing infection. So we only do them when clinically indicated, like if there's a significant change in contraction pattern or the mother feels pressure.
Okay, now stage 1 itself has two parts, latent and active. What's the latent phase like?
Latent phase is the early part, from 0 up to about 3 or sometimes 4 centimeters dilation. Contractions are usually mild to moderate, maybe 5 to 10 minutes apart, lasting 30-45 seconds. The cervix is mostly effacing, thinning out during this time. People are often coping quite well, maybe excited, maybe anxious.
Is hospital the best place for this phase?
Often no. If everything is low risk, home is often more comfortable. The
Yeah.
focus is on rest, hydration, distraction. Nursing care involves education, reassurance, and suggesting comfort measures like walking, showering, or using a birthing ball.
Then things ramp up into the active phase.
Yes, usually from about 4 centimeters up to the full 10 centimeters dilation. Now the contractions get serious stronger, longer, maybe 60-90 seconds, and closer together every 2 to 5 minutes. Dilation typically happens more quickly now. This is where intense support becomes absolutely vital.
What's the key nursing role here?
Often, continuous presence. Helping the support person, encouraging coping strategies like focused breathing through the contractions, helping with position changes, ensuring hydration, maybe assisting with pain relief options if requested, offering things like counterpressure for back pain. It's very hands-on.
And towards the very end of stage 1, as dilation nears 10 centimeters, there are signs that birth is imminent.
Definitely. This is sometimes called the transition phase, maybe 8 to 10 centimeters. Signs include intense rectal pressure, an uncontrollable urge to bear down or push, sometimes nausea or vomiting, involuntary shaking or shivering, and often a psychological shift. The person might feel overwhelmed, irritable, or suddenly very focused and determined. Seeing these signs means getting ready for stage 2.
Right, stage 2, the birth itself. This runs from full 10-centimeter dilation until the baby is born.
Stage 2 also has phases. There's often a passive phase right after full dilation, sometimes called the laboring down phase. Contractions continue, the baby descends passively, but the overwhelming urge to push might not be there yet. It's a bit of a lull.
So you don't necessarily need to push immediately at 10 centimeters.
Not always. Allowing for passive descent can conserve energy and potentially reduce pushing time. Then comes the active pushing phase, when the fetal head reaches the pelvic floor, triggering a strong, reflexive urge to bear down with contractions.
What's the best way to support someone during pushing?
Encourage them to listen to their body. Spontaneous pushing, bearing down when they feel the urge, is often more effective and less tiring than rigidly directed pushing, like holding your breath and pushing for 10 seconds. Helping them find effective positions, squatting, side lying, hands and knees can open the pelvis. And fetal heart rate needs close monitoring, often after every contraction or push during this active phase.
Okay, baby's born. But we're not done yet. Stage 3 is the delivery of the placenta. Short, but potentially risky.
Yes, stage 3 goes from the baby's birth until the placenta is expelled. Usually takes 5 to 30 minutes. The main risk here is postpartum hemorrhage, PPH.
How do you know the placenta is ready to come out?
There are classic signs of separation. The uterus contracts down firmly and feels globular, like a grapefruit. It seems to rise up in the abdomen. The umbilical cord lengthens as it detaches, and there's often a sudden gush of dark blood.
Now, the sources mention different ways to manage this stage. Active versus passive management. What's the difference and why the debate?
It's a significant clinical choice. Passive management is hands-off. You wait for those signs of separation, maybe encourage skin-to-skin contact with the baby to boost natural oxytocin, clamp the cord only after it stops pulsating, and let the placenta deliver spontaneously with maybe gentle maternal effort.
And active management.
Active management involves specific interventions to speed things up and reduce bleeding risk. Typically 3 components. 1, giving a uterotonic drug, like oxytocin injection, right as the baby is born to make the uterus contract strongly. 2, early cord clamping, usually within a minute or so. 3, applying controlled traction on the cord while stabilizing the uterus once signs of separation appear.
What's the main argument for active management?
Reduced risk of PPH. Studies show it significantly lowers the rate of heavy bleeding, over 1,000 millisecond, and reduces the average amount of blood loss, plus it shortens stage 3. Many guidelines recommend it, especially if there are risk factors for bleeding. But passive management is still a valid option, particularly in low-risk settings or based on patient preference.
Okay, placenta's out. We're finally in stage 4, immediate postpartum recovery. The first hour or two.
Yeah.
What's the focus now?
Stabilization and monitoring for complications, primarily hemorrhage. Vital signs, pulse, blood pressure, respirations, are checked frequently, maybe every 15 minutes initially. We're watching for rising pulse or falling blood pressure, though low BP can be a late sign of PPH.
And checking the uterus.
Constantly. The fundus, top of the uterus, should feel firm, like a hard ball, and be located roughly between the belly button and the pubic bone. If it feels soft or boggy, it means the uterus isn't contracting well, uterine atony, which is the leading cause of PPH, and needs immediate massage and possibly medication.
During the birth, perineal tears can happen. How are those classified?
They're graded by severity, which is crucial for proper repair and healing. A first-degree tear involves just the skin and superficial vaginal lining. Second degree goes deeper into the perineal muscles, but not the anal sphincter.
And the more serious ones?
A third-degree tear extends into the anal sphincter muscle complex. A fourth-degree tear goes all the way through the sphincter and into the lining of the rectum itself.
Ouch. Repair must be critical for those third and fourth degrees.
Absolutely essential. Meticulous surgical repair is needed to restore function and prevent long-term problems like incontinence. Assessment and documentation are key. And all this monitoring happens while the new family is often experiencing this intense mix of emotions, relief, excitement, exhaustion, hunger, maybe anxiety. It's a complex recovery phase.
So what does this all mean? We've gone from those first hormonal whispers through the intricate physics of the 5 Ps, the cardinal movements, the adaptations, and the careful navigation of the 4 stages. It really underscores that uncomplicated labor, while normal, is this incredible feat of biological engineering, a balance of immense power and really microscopic precision.
It absolutely is. And I think what the material really drives home is that providing safe, excellent care demands this dual expertise. You have to understand the physics, the angles, the diameters, the mechanics of descent, but you also have to be a truly compassionate, culturally humble advocate, skilled in trauma-informed care. The two are completely intertwined for a positive outcome.
You really can't separate the mechanics from the human experience.
No, you can't.
Okay, so as we wrap up, here's something to think about, directly linked to that physiology. We talked about maternal cardiac output peaking after the birth, reflecting this huge systemic effort. Knowing the sheer scale of that physical marathon the body has just run, how does that evidence change our perspective, maybe societally, maybe clinically, on the immediate need for true rest, focused nutrition, and uninterrupted bonding time in that critical first hour or two of stage 4? The body achieves something monumental. What level of recovery and support should we really be prioritizing right after birth?
A really important question to reflect on. Thanks for joining us on this deep dive.
We'll catch you next time.